Just in this last, 30 minutes or so, everyone checked in but Brianna, so I want to be sure that oh, I see you. You are here. Okay, good. I don't want to mark you as leaving after the exam if you were here. Okay. So, alrighty. We are talking about drugs that affect the endocrine system, mainly the drugs that are used to treat diabetes, and then drugs that affect growth hormone and antidiuretic hormone, drugs that test thyroid and adrenal gland disorders. So the particular hormones that we're talking about, these hormones work in what's called a negative feedback system, meaning that the body wants this hormone level to be in a certain, so if I took a blood test like for diabetes, I would want the blood glucose to be in a certain range, and if things got too high, then the body would stop releasing hormone, and if things got too low, it would increase the release of hormone. So going too high is a way to stop the body from releasing things that will amp up a response, and going too low will help the body decide to increase the release of hormones that so we're always trying to keep this balance, and that's a negative feedback. Is we want the variable, we want whatever it is in a state of homeostasis, and if there's an imbalance where there's too little, then the body will produce more, and if there's too much, then the body will stop production. So the first system, or the first kind of issue we're going to talk about, is diabetes mellitus, and that brings us to the function of the pancreas. So the pancreas has two functions. One is to help aid in digestion of the food we eat. That's its exocrine function. That's creating the enzymes that we eat and dumping them into the small intestine so we can break down our food. The other part, or the endocrine part of the pancreas, is the hormones that are produced in what's called the islet of Langerhans that go in the bloodstream and help us utilize glucose for metabolism. So if we've kind of narrowed in on a little portion of the pancreas, like if we looked at the cells right here, we would see the portion of the pancreas that makes the enzymes. And then here are the islets that have different kinds of cells that create the hormones that the pancreas makes. Namely, the ones that we're worried about are the hormone insulin and the hormone glucagon, because those are the hormones that keep our blood sugars in balance. So here's how it's supposed to work. We kind of started it here. The body's serum glucose, or the amount of blood sugar, should be around 70 to 100. If we eat something, the blood sugar starts to go up. Increasing the blood sugar will the pancreas will sense that increase in blood sugar, and that'll prompt the release of insulin from the pancreas. Oops. And the insulin has several important jobs to do. One is it will let glucose into the cell. We won't be able to use the glucose without insulin, which is sort of like the key to the door in order to allow glucose to come inside. So if we don't have that, we can't use the glucose, and that is how the body gets all of its energy. When the cells get what they need of the glucose, then whatever is left over can be stored in case there's a period of starvation. So one place it's stored is in the liver as glucagon or glycogen. And if we then fill up the liver storage area, then we can start to store it as fat. So maybe it's between meals, it's been a while since you got to eat, the blood glucose level starts to go down. The body needs to bring that glucose level up, especially to feed the brain because it doesn't have any reserve. So instead, the pancreas will release a hormone called glucagon. And glucagon is really meant to get these stores available to us. So it'll do something called glycogenolysis, which is really breaking down the stores in the liver so they're available in the bloodstream. And then if we use all that, it'll take the fat and do gluconeogenesis, which basically means we're using the fat to make glucose. So we use the fat to make glucose, but the problem is the byproduct is ketones, which is acid. So that's how we're supposed to run. We're supposed to be eating at regular occasions, and then we store extra, and then between meals we have sources that we can use if we need to. If someone has diabetes, which it depends on the type of diabetes they have, but then there's a problem with the available insulin, and so there's an increase in blood sugar because we can't use that sugar without the insulin itself. And so if we're going to diagnose somebody with diabetes, it would be because they have an elevated fasting blood sugar, they have an elevated hemoglobin A1C, which gives us an indication of what their blood sugar is like over time. OGGT is an oral glucose challenge test where we have them drink like a very high sugar volume orange drink and then check their blood sugar at regular intervals to see that their body is responding appropriately. And then there is a difference between type 1 and type 2. Type 1 diabetes means that there is no insulin at all. The cells in the pancreas, those beta cells that are responsible for making insulin, don't work anymore. So then we don't have insulin. And so the blood sugar gets high, and the body will start to use its alternative fuel sources, which means the patient will develop acidosis, or what we call diabetic ketoacidosis, and they can be quite sick. This is sometimes referred to as juvenile diabetes because it's sometimes found when the person is a child. It's possible to develop type 1 as an adult, but not as common. Type 2 could be child or adult onset. This is the one that's associated with obesity. Having an increase in body weight, especially in the abdomen, will change the way your body responds to insulin. It leads to an increase in insulin resistance. So the pancreas doesn't release insulin as easily, and the cells of your body do not respond to insulin as well as they used to. And so you still have available insulin, so you rarely develop acidosis, but you can become still very sick if your blood sugar gets really high. So anyone with diabetes will end up on some sort of medication regimen usually. Type 1 diabetics have to be on insulin. Type 2 diabetics have a choice. In the beginning, they can try to use oral hypoglycemics, which is what our quiz is going to be about. They can use the pills. And then as time goes on, they might need to add to that regimen. Anyone who has type 1 diabetes has to use insulin. They have no other choice. Type 2 diabetics sometimes end up needing insulin later on. But anyone who's taking any of those medications has to have a plan of what to do if their blood sugar gets too low. They should try to stick to a diabetic diet, which is an overall decrease in the amount of carbohydrates. They should have an exercise plan. And they should wear a medical alert bracelet, a safety bracelet, so that if they were found down, someone finds them unconscious, they would know, oh, I really should be checking this person's blood sugar. because that could really be what the problem is. And so we ought to be sure, since if the patient's diabetes is not under control, they will have symptoms of hyperglycemia, or if the patient is medication, they're not eating enough or they're taking too much medication, they will develop hypoglycemia. We have to be sure that we know what those symptoms are, because that's, of course, how the test questions will be asked. So, what symptoms do people have if their blood sugar is too high? Potentially. Mm-hmm. Thirsty. Mm-hmm. Peeing a lot, ketones in the urine, because that's why they have the sweet breath, because that also has a sweet smell. Excessive urination, thirst. So sometimes they call it like the polys, the three polys. It's polydipsia, polyuria, and polyphagia, which means they're hungry, thirsty, and they're peeing a lot. They can have ketones in the urine and sweet breath because the sweet breath is from the ketones. They're generally high and dry. So there's no sweating, they're very dehydrated. So it's high and dry with the polys. Um, as they get higher and higher, they might end up becoming lethargic and could lose consciousness, but they'd have to be pretty high. What about low blood sugar? Cold and clammy. Need some candy. I like that. Jittery. Mm-hmm. Fatigue. So these people are cold and clammy and jittery. They can have some confusion. They can start to get kind of irritated. They might feel hungry. And the end point is the change in level of consciousness or mental status changes as you're describing. So the big difference, which you'll always see on exams, is high and dry. So you know they're dehydrated, and they would have the polys, the thirst, hunger, and peeing. This my cat wants me to pet it. And then hypoglycemia is cold and clammy, you need some candy. I like that, but they're going to be sweaty, jittery, possibly irritated, hungry, and then both of them could end up with, lethargy, fatigue, confusion, and change in level of consciousness. But you'll always see this as sometimes a distinguishing factor, so keep that in mind. And then we have to go over our plan for hypoglycemia. So if the patient is awake, can follow directions, and can swallow, you can give them something to eat in order to bring their blood sugar up, but you want it to be something that has a high sugar content, like juice, orange juice, saltines, honey. You can give 1 tablespoon of honey. You can give 15 saltines, which would be quite a lot. 4 ounces of orange juice would be enough. Something that has a high amount. You want to try to quickly give 15 to 20 grams of carbohydrates. And then you're not done. You would have to check back with them in like 15 to 30 minutes to be sure that their sugar remains elevated after you did that. If they are unconscious, depends on where you are, what you can do. You could give the patient glucagon or IV dextrose. So treatment depends on the stores of blood sugar and the level of consciousness and ability to swallow. So here were some of the things we could do if you were awake. If you are unable to swallow, and unconscious, the person can get glucagon. But it's going to take 20 minutes to work. So people sometimes carry around glucagon kits, and if they become unconscious, somebody could give them a subcutaneous dose of glucagon, almost like carrying around an EpiPen. And it's going to take them 20 minutes really to come to, and then you can give them something to eat at that time. However, and this is always a test question, so put lots of stars by it, glucagon doesn't work. Oh, cool. Did they do okay, Aisha? Did you?
Yeah, she was fine. Her blood sugar was 40 at the HS med pass, but she was able to still swallow. So she
Okay.
was given, I gave her the glucose gel first, and then at recheck it only went to 45, 54. And
Oh.
then I gave her the IM glucagon, and then it went to 97. So she was fine.
Oh,
And I
wow.
just had to fax the doctor and update him.
Oh, wow. Yeah. So that was well handled. So she kept checking back with the patient and then giving more. Whoa, someone had a blood sugar of 1,280. So that obviously was the other direction. You'll be surprised, like type 2 diabetics can walk around with really high blood sugars and not know it because it gets higher and higher over time. That's higher than my best. My best was 800 and something. That was like a pre-op patient that we got labs on, and I was like, whoa, I can't believe that yep, totally asymptomatic, just wandering around. Like, okay. Um, so the thing with glucagon, which will always be on the exam, is that you cannot use glucagon if the patient is starved, meaning they have no sugar storage. Um, oh gosh, that's too bad, Natalie. That will be the wrong thing to do. Um, yeah, good. I'm sure you did. So if you're giving somebody glucagon, they can't be someone that, has muscle wasting or has really, really thin because of cancer, or maybe that they have a eating disorder and have, excuse me, anorexia. You can't give them glucagon because they won't have any storage available to them in their liver. Because remember, glucagon is trying to access the storage depots that we have for glucose, first and foremost from the liver, and then potentially from fat. But if the patient is very, very thin and is more of a starved appearance, they don't have that storage, so the glucagon won't work. So there's always a question about that, so remember that. And then certainly the thing that would work the fastest would, if they had IV access, you could give them an amp of D50, which is 50% dextrose that you would just give to their IV, and that, of course, would work the quickest. So then we're going to start to talk about the oral hypoglycemics. So this is the quiz information, and the quiz will be, let me just see how far down the oral hypoglycemics go. So it's slides 15 to 23, because that's all the information on the oral hypoglycemics. That's what the quiz will be about next class. So oral hypoglycemics are pills that bring the blood sugar down, and they are used in patients that can still make some insulin. So typically with type 2 diabetics. They can be taken alone or in combination. We always have to worry about the directions. Some of them have to be taken with the first bite of a meal. Some of them have to be taken with, before people eat. So you always have to be careful about what those directions are. Every medication that we talk about that has to do with diabetes, there's always a risk of hypoglycemia, and that's why we want the patient to have a good plan for that. And any diabetic shouldn't be drinking alcohol, but there is many medication interactions with alcohol in these medicines, so they shouldn't do it anyways. But certainly diabetics shouldn't drink alcohol because it's very, very high carbohydrates. So the first group, the first family of medications that's considered an oral hypoglycemic, the first family is called sulfonylurea, and our prototype medication is the glipizide. And what glipizide does is it tells the pancreas to release more insulin than it has been. Because part of the problem with type 2 diabetes, people who are obese, they develop resistance to high blood sugars and resistance to insulin. So this pill is sort of a reminder, like, hey, pancreas, please make some more insulin. We need more in order to use our blood sugar. So the person takes it as a pill every day, 30 minutes prior to a meal. So it could be like 30 minutes before they usually eat breakfast or 30 minutes before they usually eat lunch, whatever would be a good routine for them. The side effects are nausea, diarrhea that tend to go away as the patient's been using it, and some mild hypoglycemia, because if the person takes a pill that's going to be working all day, they do have to be sure they eat. The adverse effects could be severe hypoglycemia, so their blood sugar went down really, really low, which is more common if the patient mixes this medicine with alcohol or NSAIDs, and could potentially lead to hepatotoxicity, so they will have to have their liver tested. And then what are the blood tests we do to check liver function? Nope, that's the kidney. AST is one of them. And Billy. There you go. Natalie has all of them. ALT, AST, and bilirubin. So we're looking at the liver function, those liver enzymes, and the bilirubin, because when people have liver dysfunction, they will have, the jaundice, white stool, dark urine. Probably any person that is a diabetic will end up needing, Lillian, to have the hemoglobin A1C checked periodically to be sure how well their blood sugar is under control, like is the medication working. But in terms of being sure that they're okay with liver toxicity, we would check the liver enzymes and the bilirubin. The other issue, besides alcohol interfering with the medication and making it more toxic, the person can also experience that disulfiram reaction, like we talked about with some of those antibiotics, where they get the flushing, nausea, vomiting, palpitations, they don't feel good. So they have to worry about that too. The next family is megalotinides, and rapiglinide is the medication that we have to remember. That's our prototype. It actually works very, very similar to glipizide. It stimulates the pancreas to release insulin. People are more likely going to be on glipizide because you only have to take it once a day. The big difference is that for rapiglinide, you have to take it 3 times a day. You take it with your meals. So you take 30 minutes before each meal that you eat. So if you skip a meal because you're not eating, then you wouldn't take it. So instead, maybe you don't ever eat breakfast, so then you would take 2 pills that day. If you want to eat more than 3 meals, you can take the medicine up to 4 times per day. So I guess it depends on the person. Do they skip meals, and so you'd rather be sure that they ate before you give them the medicine, or is this too hard for somebody to remember to take these medications all throughout the day? But they work the same, it's just the directions are different. Side effects, nausea, diarrhea, and mild hypoglycemia. So it's a little bit, you don't have the hepatotoxicity worry and the disulfiram reaction that we had to worry about with glipizide. Next medication, this is the one we'll stop with before our lunch break, is metformin, which is very, very common medication for people to be on who have type 2 diabetes. Occasionally, glipizide and metformin will be given together as a combo medication, which is called glucophage or glucotrol when it's added to something else. So you'll notice that can happen sometimes. The metformin works in a different way than rapiglimide and glipizide. Instead of making the pancreas release more insulin, this actually helps the body use the insulin better. So it decreases the absorption of glucose, meaning once we eat something, the same amount of sugar isn't going to be absorbed into our bloodstream. So that's good. It decreases the synthesis of glucose in the liver, so we don't have to worry when glucagon is being released of our sugar going up. And reduces insulin resistance to the cells of the body, which means um, the cells are better able to use the insulin that's available. So that's why it's really good to take like glipizide and metformin, because then you're increasing the ability of the cells to use the insulin, and you're making the pancreas release more insulin. It's a very good drug combination. You can, if you took metformin by itself, you could have low blood sugar, but not usually as severe as some of the other medications. Here's the side effects. What people complain about the most is the diarrhea. It's probably because you're changing the way glucose is absorbed in the intestine, so they tend to have more bloating, cramping, diarrhea, but that goes away with time. So if they can just get through it, then they should be okay. Some other issues that can develop, it could change the way the B vitamins are absorbed in your intestines, so you could develop an anemia related to that. So some of those symptoms that are listed are just the usual symptoms for anemia. Cherry or a dark red tongue is common with those B vitamin anemias. And the other thing, and this will always be a test question, is the possibility of lactic acidosis. So, and this increases if there's a kidney issue. So if the patient is sick and you're worried that their kidney isn't getting enough blood flow, then they're at increased risk for lactic acidosis. And because of that, you always will have to hold metformin prior to surgery or any scan that requires imaging, because that could potentially put their kidneys at risk, and we don't want them to develop lactic acidosis. So we'll stop there and we come back, then we'll finish and keep going with this other material. So I will see you guys back at 1 o'clock.